Okay, let's get started, everyone. Let me make sure we're good here. Hey, everyone, I'm Russell Berg. I'm basically, most of you know me. I'm the ambulatory chief resident for Harborview for Adult Medicine Clinic. And we are very lucky to be joined today by Jong, who's a fourth-year psychiatry resident who will be helping us with this talk today. We're going to be discussing mental health for primary care in the context of the COVID pandemic. It looks like I can see the chat at the same time, so if anyone wants to send questions or thoughts or comments throughout the talk, please send them to me. I think I'll be able to simultaneously moderate, and there'll be some audience participation as well that we can do through chat. So the plan for today, and can I just get some quick responses through text? Can everyone hear me okay? Okay, great. The plan for today is we'll briefly just touch upon and share some of our experience with the destabilizing effect of the COVID pandemic and home quarantine. It's affecting all aspects of the healthcare that we provide, and in particular is having an impact on mental health of our patients. With the help of Dr. Jong, we're going to work through a couple cases that have come from my experience providing primary care telemedicine through AMC. Case number 1 is called "Is Anyone Feeling Anxious?" Case number 2, "I'm Upside Down," and case number 3 is "A Tremendous Challenge," each of which is highlighting kind of an exacerbation of some pretty common mood disorders. And then we'll take a little bit of a break if we have some time, depending on our pace, and then move on to primary care management of substance use disorders via telemedicine. I'll give you a methadone update, an OBOT update, meaning office-based opiate treatment via Suboxone, an update of our practices locally and within the state, and walk through an alcohol use disorder case and management. That's been an unfolding saga via telephone visits for one of my primary care patients. So here was a graphic that was forwarded to me by Michael Wenger, who's a counselor, a psychologist in our clinic. And this graph here just shows on the y-axis kind of our emotional highs and lows. And on the x-axis is time. And this is meant to kind of just show how destabilizing a pandemic or a disaster can be on our emotional state. And just kind of walking through this curve reminded me of how labile my own emotions have felt. I don't know about you guys, but on the left side of the graph, we have this pre-disaster phase where a warning is sounded, the threat is appreciated, and we start to feel the impact of that threat. In this case, escalating COVID infection rates, shutting down elective procedures, scrubbing and trimming down of outpatient management, visitor restrictions, etc., that have been going on. That incurs an emotional burden. But then there's this well-named heroic phase where everyone gets their act together and people feel like they are making progress and that they have some degree of control over the situation and things they can do. And people generally feel pretty good during that heroic phase. There's a honeymoon period of community cohesion where you feel like you're really working well as a team. And then the slope goes down again. There's a period of disillusionment, and then you can see there's bumps in the emotional kind of status, things going up and down, being triggered perhaps by additional waves of COVID infection in our case, or I think very prominently in our current situation, the financial difficulties that our system is facing, kind of disillusionment, meaning we've worked so hard, we've achieved so much, and yet we still have all these problems going on. And then that kind of whole period of dramatic ups and downs is thought of to last for something like a year. And then the reconstruction phase sets in where you are working to restore operations as usual or to a new normal, and your emotional kind of your emotional status gradually improves with some minor setbacks along the way. So I saw a lot of my own emotional trajectory well recapitulated in this graph here. Wendy asked where this graph is from. This was forwarded to me by my social worker in my clinic, but I don't have a citation for it, but I'll find it for you. There's lots of other destabilizing effects. Something that I've been reading about and following is how domestic abuse cases have been rising in the context of COVID. People are stuck at home. People can't escape their abusers. Confidential shelter access is restricted. And so the UN issued a warning that, they're estimating something like 30 million more cases of domestic violence. And you can imagine how this could certainly have a destabilizing effect on our patients' psychiatric health. This was some general good advice that I got from psychiatry.org, which has a whole special section on what to do about coronavirus. And this advice is for healthcare workers, but also for patients. And it really just says, it acknowledges how, in particular, number 4, limiting media exposure. Use media enough to make informed decisions and then turn it off. Just reality and the world is so triggering. And number 5, anticipate and address stress reactions. The extreme emotions many of us and our patients are feeling actually might be considered normal in the context of what's going on. And it's important to kind of recognize them and anticipate them and try and work to protect ourselves as much as possible in the context of so much, true external turmoil. So I'm going to move on to some cases. Case number 1 is anyone feeling anxious. And this is a patient of mine, a 54-year-old woman who has a medical history of diabetes, anxiety, which has typically been very mild and untreated, who presents for telephone follow-up with concern for left arm and leg paresthesias. Her daughter, with whom she lives, her adult daughter, developed fever and a cough 4 weeks ago and was referred for outpatient testing for COVID-19 and tested positive for COVID-19. A week later, the patient developed similar symptoms and was also referred to testing and also tested positive for coronavirus, but had fairly mild symptoms. As soon as she received the positive test result, she developed left arm and left leg paresthesias. She tells me that they feel numb and lazy. The episodes are associated with chest pressure and some shortness of breath, and she tells me, I feel like I will faint. And these episodes last 30 minutes to 2 hours at a time, and she's feeling them about 2 to 4 times per week. So this information was conveyed to me during this telephone encounter. And I kind of wanted to pause here and maybe through the chat, what people think out there, if they heard this on a telephone visit, what would their next steps be? Okay, I'm getting some private messages. Someone sent me a private message. They would refer this patient to the emergency department. I think that's the correct answer. This patient is reporting acute episodes of paresthesias. There might be some subjective weakness. My concern was for some type of stuttering intracranial process. I was wondering maybe if she's having TIAs. Or perhaps she's having some arrhythmia, or perhaps she's having some cardiopulmonary process that's affecting her sensation. There's also clearly the context of anxiety here. So I did refer her to the emergency department for head imaging, and these were negative for intracranial process. She was discharged home. And Overall, she this on follow-up says she's feeling much better. I see her on the phone for follow-up. She's feeling much better from a respiratory perspective. Her cough is resolved, her fever is resolved, and she's read about how people with COVID can feel better and then get much worse. And she tells me that she's worried that this might happen to her and she could die in her sleep. She's continuing to feel these paresthesias and dyspneas, and now it's about twice per week. So what do you guys think is going on? Okay, so this I think would be classified as a panic attack. Panic attacks are characterized by a sudden onset and rapid escalation within minutes of extreme fear or anxiety. And this patient here has fear of dying, is reporting dyspnea, is reporting chest pain, is reporting dizziness, and is reporting paresthesias with these episodes. So this would classify as a panic attack. Some other overlap here that it might have, and I would love to hear Kat's perspective on this too, is whether this might also be a manifestation of illness anxiety disorder. The other name for this is hypochondriasis, or someone, being a hypochondriac. Kat, I'd love to hear your perspective about how to decide if someone's anxiety about a real pandemic or having a real infection, deciding whether their response to it is kind of appropriate or over-exuberant and inappropriate.
Yeah, I mean, I think it is really challenging in this setting, especially, because COVID is a real threat to people and people can die from it. And so to sort of see people who are acutely anxious, I think what I like to think about is sort of comparing it to like when people are presenting to you with sort of a more traditional medical complaint, right? Is thinking about the qualities of the symptoms, sort of like timeline of them, history. If this is someone, for example, who previously was really worried about having cancer, right? And then, maybe before that, like something else that they had read in the paper or sort of other things that were happening in the world that might point to like a more general like anxiety disorder or like, somatic disorder versus like somebody who's like never had any symptoms before, who is saying like, hey, all of this stuff that I'm reading right now just has me really scared. That might point you more in this like very like either a specific phobia direction or like a sort of more extreme response, like an acute stress kind of reaction versus like a generalized anxiety.
Got it. So some really critical history to get is to see if they've had any comparable reactions to other kind of health threats in the past or other triggers that might be other manifestations of an underlying panic or anxiety disorder.
Yeah.
Yeah. So, I felt comfortable characterizing this as a panic attack, given that she didn't really have any other prior comparable history of this. I wasn't comfortable diagnosing her with a panic disorder, but that is that is what you're getting at. Is this a mark of an underlying predisposition to this type of reaction? And then, so if this were a pattern of recurrent panic attacks, I wanted to move into a very quick broad strokes overview of treatment of panic disorder. I think most of us know that anxiety disorders respond very, very nicely to SSRIs and or CBT. And in fact, the response to SSRI treatment for anxiety disorder seems to be a bit better than SSRI responses to treatment of depression overall. Kat, do you have a favorite SSRI that you tend to go to for treatment of panic disorder?
Other than saying not paroxetine, I tend to, it really depends on their medication list. I think like our go-tos are often like sertraline or escitalopram if they have a lot of meds on their list, just because those tend to be pretty well tolerated. And then if people are people who like forget to take medications, fluoxetine is nice because it has a long half-life, but it has more like drug-drug interactions. So those are, I feel like, my top three that I tend to prescribe as like a first line.
Great, thank you for that. And then if the patient really has not responded well to an SSRI, the options are to either switch to a different SSRI or to switch classes. And that seems to be a theme that we'll build on a little bit through the other cases. The SNRI that I've seen most commonly prescribed is venlafaxine. And then the question of,
and can I just
please.
I jump in for a second? So I think this is sort of one thing from a psychiatry perspective, is especially if you're starting with someone on a drug like sertraline that has like a very high maximum dose of, like up to 200, is that sometimes we see people with anxiety disorders actually kind of needing to get to a higher dose in order to get that therapeutic effect. And we'll often get a referral when they've only been on like 50 or 100. And so it's really helpful to sort of say, like, have they had a real therapeutic trial and not responded before kind of going to augmentation or switching drugs?
That's very useful, thank you. Yeah, anxiety disorders tend to require higher doses. So make sure you give SSRI treatment a fair shake. If there's partial response, there's some other options, gabapentin, Lyrica, mirtazapine, and TCAs. Something I wondered, Kat, if you could weigh in is when do you think it's appropriate to try giving a rescue medication where patients can try and abort a panic attack? When is it appropriate to give benzos or other agents like that?
That's the $1,000,000 question. But I think, especially in people who are already kind of, you feel like they're trying the SSRI and they're doing, reasonably well, but they're still kind of having some kind of like paralyzing event where they're like not able to leave their house, or like they're saying like, I'm driving and I'm having to pull over on the freeway, or, things like that. Is it sort of like, I think about it sort of in the same context as like if somebody has the fear of flying and needs to get on an airplane to go, see like family or do a meeting, that those are kind of appropriate times for giving it a trial just so that they have it, and then sort of in a very limited number of pills. I never like to give people kind of like a PRN to take every day, because then people get sort of like psychologically conditioned that that's the only way to feel good.
Right, yeah, and so some of the things I'm hearing, if you are considering a benzodiazepine, there should be a really discrete kind of trigger that can be identified, like you mentioned, flying. Very short courses should be used PRN, but kind of with very strict instructions. And something else I think that's important is that I really would not recommend using benzodiazepines in patients with a substance use disorder history. I think that's high risk. Okay, let's move on. But just to review some of the other pearls for SSRIs, we talked a little bit about this, but for anxiety disorders, the rule of thumb for initiating SSRIs is to start at a low dose and go slow. You can start at the initial dose for 1 week, and then after that, double the dose, and then can up titrate every 2 weeks from then on. There's lots of different ways to do that, but Kat's excellent guidance was you really should try and get up to a maximum or maximally tolerated dose for an SSRI before determining whether or not there's been adequate treatment response. And that can help, help guide when to class switch.
Yeah, in terms of the SSRI, I think in particular with anxiety patients, it's really important to sort of do, the really good anticipatory guidance about side effects early, because, people who are very thematically focused really do notice either like the GI upset or like sexual side effects, and might like panic about them if you don't tell them ahead of time. And so I often just tell people like what they might expect and that I expect it to go away. And if it doesn't and they're concerned about it, to let me know. And that way, there's not like a surprise about it.
That's great advice. Thank you. Okay, I wanted to include this because I think there's a lot of, we all know that CBT and pharmacotherapy for treatment of many mood disorders um, are effective alone, but more effective together. This randomized control trial that I found showed that to be the case, but also interestingly showed that 6 months after treatment, um, the combination, the addition of CBT led to longer uh, response rates 6 months after. So CBT seems to have kind of a more lasting effect on control of panic disorder than medication treatment alone, which I thought was really interesting. And I think doing them together is almost always the best thing. Some of us may be wondering how we can get our patients CBT, provide them with therapy in the context of kind of COVID and quarantine and offices being closed all over the place. This was a study that was published in JAMA Psychiatry this month that looked at the effect of internet versus face-to-face CBT for health anxiety. And it was a randomized non-inferiority trial was the design. 200 patients with health anxiety were randomized to 12 weeks of internet-delivered CBT. And it was actually via kind of like e-care type email messages versus face-to-face cognitive behavioral therapy. The health anxiety inventory was administered with each session, and that the CBT was found, text-delivered CBT versus face-to-face was found to be non-inferior. The therapist spent 10 minutes per patient per week in online treatment versus 45 minutes for face-to-face CBT, which is an amazing difference in time. And the cost difference per patient was incredible, was almost $4,000 per patient. With very similar efficacy. So I think this is good evidence that we can deliver these services effectively through the computer and in the context of home quarantine. Let's move on to case number 2. I'm upside down. This is a 62-year-old male patient of mine. He has a history of PTSD. He has a history of childhood sexual trauma. He has depression. He has opiate use disorder, currently in sustained remission on Suboxone. He has benzodiazepine dependence and alcohol dependence, so a very complex psychiatric milieu. He tells me that things are not right. I'm upside down. I'm not sleeping. Anxiety is high. He tells me it's not the kind of anxiety that I want clonazepam for. He does have a history of requesting benzos for anxiety, but tells me it's feels like depression. I'm sleeping a lot. These are signs of depression. He tells me he feels numb. He feels slow, and his daughter mailed him a book that they could read together, and he just can't concentrate on this book. The patient's been on paroxetine since 1994. He doesn't think his depression has ever been well controlled with medications. And I looked in his MAR, and it looks like he's taken fluoxetine and citalopram over the last 20 years. He doesn't think these ever helped much. He denies side effects from SSRIs, and he also denies racing thoughts, agitation, disinhibition, or other symptoms of mania. Or any prior history of mania. He's actively involved in weekly phone therapy with his counselor. That's mostly centered on alcohol use disorder, but also general mental health check-in. And his PHQ-9 over the phone with me is 17. He denies suicidal ideation. So what do we think is going on with this gentleman? This guy seems to be having a major depressive episode. It's hard to know whether this is related to his substance use, because it could be a substance use associated mood disorder. But he does have a long history of depression that seems to not be well controlled with SSRIs and is acutely exacerbated. And so this kind of led me to the topic of what to do when SSRIs don't work, and the management of SSRI-resistant depressive episodes. This here is a meta-analysis that looked at comparing changing of medications within a class, so for instance, within the SSRI class, or comparing it to class switching of pharmacological therapy for depression. In this study, patients were randomized to switch from to switch to a non-SSRI antidepressant. Those who did switch to a non-SSRI antidepressants were more likely to experience remission, but interestingly, they did seem to have worse side effects. And I think the thought about this is that really SSRIs are generally the best tolerated class of antidepressants. And so while switching a patient to a different class may give them a better chance of achieving remission, they're also slightly less likely to tolerate non-SSRI classes of medications. So I wanted to throw this to Kat briefly to kind of just give us an insight into kind of expert thoughts about when you augment someone's treatment for depression with an additional agent such as bupropion or Wellbutrin, or when you think about switching to a different class.
Yeah, I mean, I think I like your outline here in terms of like partial response to SSRI. I think like one of the sort of more like landmark papers in the psychiatry world is the STAR-D study that looked at kind of initiating an SSRI and then, you know, depending on if there was response or partial response, adding, you know, one of the augmentation agents versus, you know, switching to a different agent. And, you know, there's usually considered like less likely to respond to an additional SSRI versus like augmentation is what we've seen. You know, one reason to switch to another SSRI is that they actually responded really well, but there was some, you know, like side effects that, you know, you feel like is more specific to that agent, or like it cross-reacted with a different medication that they're on, or you are looking for something that just like, you know, again, has a higher dose range. So those are reasons. In terms of switching to another agent, you know, I often think like if they had a good response, but just not great, that would be a reason. Yeah, or if I think there's someone who kind of is benefiting from one of the effects that the SSRI has that the other augmentation agent doesn't. And I think that keeping the SSRI on has this benefit of letting you not have to dose the other medications quite as high, and a lot of those other medications tend to have more side effects. And so, especially like atypical, you know, for people who just have kind of unipolar depression, I try to keep those doses as low as possible.
Thank you for that. That's really helpful. So there is, building on some of the things you said, there is evidence that combination of different antidepressants, so augmentation, can achieve good results with lower doses of the second medication. I'm just reinforcing what you said. And then kind of guidance for us, if a patient didn't tolerate an SSRI due to side effects, or the dose of that side effect was limited by side effects, that medication really shouldn't be continued with another medication added on top of it. That medication should be switched. It doesn't necessarily mean you need to switch classes. For instance, if someone's having sexual side effects from an SSRI, you can try a different SSRI before deciding to switch classes or before deciding to augment. And that we really should try our best to make one medication change at a time. So for instance, if an SSRI is intolerable due to side effects, and they're also not getting good effect from it, it doesn't make sense to change the SSRI and augment. You should do it in a stepwise fashion so that we know what change or what agent is most effective for that patient.
And I just wanted to put in a plug here because there's been, you know, a little bit more literature recently in the last year or so about, you know, the antidepressant discontinuation. And to just sort of think about that in terms of like if you're having somebody switch agents and they're noticing like worsening symptoms or kind of additional side effects, just to have that on your brain as a possibility. And so if you're like adding another agent, sometimes you just might want to do it very slowly or consult us actually, like if you have a complicated sort of situation with cross tapering, because that's something that we are actually like quite sort of familiar about. And sometimes with people who've been on these medications for years, it can take weeks or months to do in a way that sort of makes the patient feel comfortable.
Great, thank you, Kat. Okay, I did get some questions about any resources for CBT in the community. Is there an expansion in capacity during the pandemic? And Kat responded that unfortunately, the psych resident clinic is full or over capacity, but does have CBT openings every year if you have patients you're following who can tolerate weekly therapy. I do also know that, for instance, our psychologists in adult medicine clinic and BHIP program are able to provide counseling services and can connect people with CBT groups that are more available. And also I was referred to this wonderful group, NAMI, that has expanded virtual support groups during the COVID pandemic. And those are widely available and don't need a formal diagnosis and actually don't need a referral either. So are good, a very good resource for patients. I got a question about augmentation with the second generation antipsychotic and who might be a good patient for that route. To
Kat. It's a great question. It's something that I think has been marketed super heavily. Abilify a couple years ago when I was in medical school was the #1 grossing medication in the United States because it got that approval for treatment-resistant depression. I really weigh the risks and benefits to the patient in terms of like what their symptoms look like because of the metabolic side effects. So, younger, healthier patient, but with really treatment-resistant depression, but not having any kind of like metabolic abnormalities would be a good candidate, like somebody who for whatever reason also hasn't tolerated one of the other augmentation agents. So it's not usually my first line of augmentation, but I have patients who've done really well on it. Also like people with kind of vaguely sort of psychotic, compulsive, or like delusional tone or flavor to their depression. So like as an example, on my panel, I have people who have OCD or kind of they get a little bit paranoid when they're feeling very depressed. Those people often respond really well to augmentation with an antipsychotic. Just, I have people on like 1 or 2 milligrams of Abilify in addition to, sertraline as an example.
Great, thank you for that. Okay, we're going to move on to case number 3, a tremendous challenge. This is one of my panel patients, 64-year-old man. He's a former district attorney, so highly functional, highly educated individual. He has a history of bipolar 1 that's been well controlled on lithium for years. Hypothyroidism secondary to lithium. He has hypertension, and he's been being seen with accompanied by his daughter at home via Zoom for follow-up. The chief complaint is insomnia, and his bipolar has been very well controlled with lithium monotherapy for 5 years. He underwent, multiple medication trials years ago in Mexico before he moved to the US. And when he moved to the US and established with me, he had been on lithium monotherapy for years already. Prior kind of exacerbations of his bipolar have ranged from very mild to very severe. And in fact, about 5 years ago, he was having a manic episode and as part of that started choking his daughter and was really out of control. So typically very well controlled with lithium, but has a history of very severe disease. He typically sleeps well, but for the last 2 weeks has only been going to sleep at 3 or 4 o'clock in the morning and is up just a couple hours later to watch the morning news. He tells me he has a lot to tell me. He tells me the world is facing a terrible crisis right now. It's such a tremendous challenge that we've never faced before. We need to do whatever we can to stay safe and prepared. He goes on, and he's been working to try to coordinate volunteering at a food bank. He's been getting his wife to sew masks. and he's working to learn whatever he can about COVID-19 vaccine development. He thinks he might have something to offer the global rush to develop a vaccine. During the telemedicine encounter, he frequently stands up from the dining room table and he's pacing while he's talking. He's also gesturing quite a bit, and it's challenging to follow everything he's saying. Over the last 6 months, he successfully and intentionally lost about 10 pounds with exercise and diet. And at his last visit, his hydrochlorothiazide was stopped by a different provider as his blood pressure had normalized, and now he's only continuing on amlodipine monotherapy for management of his blood pressure. That happened about 2 months ago. So I wondered what people think might be going on. Give you a couple minutes to think about it and what you might do next for this patient. Okay, so what do you grade? So there's a comment from Anisha, maybe check his TSH and check a lithium level. I think that's a great start. So Anisha perhaps is wondering if he is perhaps iatrogenically hyperthyroid, as he's lost some weight, and maybe we're overdosing him with the levothyroxine and making him very activated. She also asked that we check lithium levels, and that's a very astute thing to do. Lithium needs to be monitored periodically with a lithium level, with TSH, and with an assessment of renal function. And that should be done regularly, typically at least every 6 months. That was done for this patient, and it was found out that his lithium level was subtherapeutic. Does anyone out there have a thought as to why his lithium level might be subtherapeutic? There's a clue in the case. Yes, great. Anisha is winning all the points. She asked if it was the thiazide diuretic, and that's right. This case is just to highlight a big reason why lithium levels need to be serially monitored is because lithium metabolism is complex. It's renally cleared, and hydrochlorothiazide thiazide diuretics can increase serum lithium concentrations. And so he was stable on hydrochlorothiazide and lithium for a long time. And the lithium was stopped because his blood pressure had improved via exercise and weight loss. And so likely his lithium level dropped because of stopping of the thiazide. So just to reinforce an example of why it's so important to check lithium levels frequently. This gentleman, likely because of his low subtherapeutic lithium level, was experiencing a manic episode. These are defined by at least a week of increased energy or activity with at least 3 of grandiosity, decreased need for sleep, pressured speech, flight of ideas, distractibility, and an increased goal or directed activity or psychomotor activity. He luckily was not exhibiting any risky activities. And of course, these episodes need to cause impairment in functioning. That can be a little bit more difficult when people are on home quarantine and not necessarily working, etc. But I did get some supportive information from his daughter that she was very concerned about him, and she was worried he wasn't able to take care of himself. So what do you do here? In this case, the patient's lithium dosing either needed to be carefully increased or his hydrochlorothiazide should be restarted and maybe holding the amlodipine to kind of get him back to where he was. But I wondered from Kat if you can give us kind of any tips on what we should be thinking about if we encounter an acute episode of mania when we're talking with our patient, and if there's any kind of initial stabilization that we should undertake before seeking expert opinion.
Yeah, I mean, I think that, when you see mania in the office setting, it can be a little bit scary sometimes. And I think just like any serious illness, you want to think about, like, first and foremost, like, does this person actually need to go to the ER if they're, pressured and grandiose and hasn't been sleeping? Are they at risk for injuring themselves potentially? It's one of those few situations where someone might not say that they're, suicidal or homicidal, but be at high risk of, personal injury due to kind of like change from baseline. And, sort of like a bipolar 1 episode is considered an emergency. Screening for, like, do you think potentially that there could be something else causing this? Like, for instance, methamphetamine. Is something I always think about. Like, does this person actually have a family history or a personal history of manic episodes? That, like, yeah, I'm convinced this is just, not just, but like is a manic episode, because there are just tons of people who have a bipolar 1 diagnosis on their chart who don't have bipolar disorder. So, if you're looking at someone who you think, hey, I think this person is manic, rule out everything else, and definitely worth giving us a call. In terms of just like sort of immediate stabilization, if you're like, well, this person seems otherwise like they could manage themselves, to get to that psychiatric follow-up, like, you could think about, like, would they be willing to increase their lithium example, right? If they're taking it and they've other, like, they just happened to go down, the hydrochlorothiazide changed. This would actually be a great time to think about, like, could I add a benzo for short-term use to help them just get their sleep schedule back to normal? We are really reluctant sometimes to add benzos, but bipolar 1 mania is one of the settings where they help a lot. So just thinking about those different options.
Great, thank you for that. Thank you for that feedback. Yeah, safety assessment seems to be paramount. He was really not at a risk for self-harm or harming others at this point. And I really appreciate that. Mania can be, can become a psychiatric emergency very, very easily. Okay, well, so we're now done with the mood cases. We covered panic disorder in the context of anxiety. We covered depression, and we covered a manic episode in the context of bipolar. Quick question from Vince is, what is the time frame you would expect to see an increase in lithium having an effect on the patient's manic episode? That's a good question.
Yeah, I mean, you can get lithium levels up to therapeutic sort of within a couple of half-lives. So they'll, within sort of like 1 or 2 days, you might sort of notice that you're like making a difference. But obviously sort of monitoring blood levels over that time. Like we have definitely, like, we'll start lithium in the PEZ as an example, right? If someone's been off of it, or something like that. And so, yeah, if you're thinking about like medications that you can quickly give, like if you think someone is becoming manic and has a history of mania, but you don't think that they're quite needing to go to the ER, right? You can, the medications that you can really quickly up titrate are lithium and Depakote. And often that's just a patient preference thing in terms of being able to, do that within a couple of days and get levels. If you think that someone is reliable, you can start either of those, sort of titrate and check levels. And, that might be a situation where you would give them, a dose of like clonazepam to help them sleep that night. So Wendy asked a question about tips on convincing a manic patient to start taking their meds. It really, that's one of our biggest challenges. And like, we'll spend, like an hour in the office kind of trying to say, like, this is why you should really take this. I think often if they do have friends or family who they're with, or sort of recognize like, hey, in the past when you were manic, you spent all your money, or like got kicked out of the house, or like, hey, you really love this job, you don't want to lose it. Or, telling them, hey, right now it seems like you're doing okay, but if you don't take this medication, you could end up back in the hospital, and that's really not what you or I want. And I always tell people, I'm really sort of upfront about that and say, like, look, if I don't think you're safe, I am going to have to refer you and, have somebody else make that decision about whether you need to be in the hospital or not. And so, I try to be really upfront about sort of the different possibilities that could happen and say like, hey, if you restart your medication now, like this is sort of the safest course of action, and it helps you avoid things that you don't want.
Great, thank you for that. Yes, getting collateral and allies to help management of a decompensated bipolar patient or patient in a manic episode is absolutely critical. Kat, I wanted to thank you so much. We're wrapped up with the mood cases, and I'm going to move on to some substance use disorder cases. You're welcome to continue with us and offer your expertise, but I know you have your didactics to get to as well. We so much appreciate your help.
Cool. I'll hang out for a little bit, and then I might jump off to my other didactics at 10.
Okay, great. That took a nice chunk of time, so I'm going to move through the substance use slides pretty quickly, but I'll keep track of questions coming in through the chat as well. I wanted to touch upon substance use disorder treatment in the era of telemedicine and COVID. We've already talked about some of the destabilizing effects of the pandemic on mental health. There are some particularly destabilizing and triggering effects on substance use disorders. I want to talk about changes to methadone rules as a result of the pandemic, changes to Suboxone rules and treatment models, and finish up with an alcohol use disorder case and telemanagement of it from my own panel. So there's been a lot of coverage in the lay media about effects of the pandemic on substance use disorders, in particular alcohol use disorder. I like this term, a quarantini, anyone. This article is from the New York Times. And, it just kind of speaks to how blurred the lines between reasonable and safe drinking or low risk drinking and excessive or high risk drinking can be when you're at home all the time, when you have ready access to alcohol because you're at home. You don't have to go into work. You can, very easily covertly drink a beverage through a mug on a Zoom call. No one can smell your breath. And so there's a number of the implicit barriers, softer barriers to excessive alcohol use have been removed. And that might make it easier for alcohol use to get out of control. And also just the stress of the situation. Spirit sales are up by 75%, beer's up by 66%, and wine sales are up by 42% year on year. Some of that is probably due to people stockpiling alcohol, but it does seem that overall alcohol consumption is up since the start of the COVID pandemic. And then this article here also from the New York Times talked about how in-person addiction support meetings, many have been banned, and millions of people struggling with substance use disorders are finding it more challenging as their safety nets and support structures have been put on hold from the pandemic. I thought this was an interesting story that came up. As many of you know, homeless people in King County who are COVID positive have been moved out of shelters into quarantine sites, and some of those sites have been continuing to offer beer and cigarettes to the clients or residents there, not paid for with public money, but a kind of as part of a harm reduction model to keep people staying in these quarantine sites. They cannot be involuntarily quarantined. So there's the idea that if you can provide them with the beer and cigarettes that they would typically be consuming, providing them on site, it can keep them around in a safer setting. Tobacco sales have also spiked recently. That seems again to be stockpiling. And then interestingly, tobacco shops and smoke shops were called essential services, even though, and so those smoke shops were kept open, even in places like Italy during quarantine. And of course, tobacco use is likely a risk factor for severe COVID-19 disease. I thought this opinion piece from the BMJ was really funny, kind of highlighting the hypocrisy of that, where Altria, the holding company for Philip Morris, closed one of its factories in Virginia after two employees tested positive for COVID-19, and the chief financial officer stated that the company is committed to protecting the safety and well-being of our employees, and etc. Of course, completely ignoring the fact that tobacco kills millions of people a year, more than COVID will, and that's kind of being ignored. In South Africa, and in Thailand as well, there was kind of a recognition or a thought that alcohol use and tobacco use often occurs in a kind of congregate settings, in social settings, and they decided to pretty abruptly ban alcohol and cigarette sales in South Africa to keep people at home and to keep them from gathering in groups and drinking. It seems to have had some pretty detrimental effects, and they're likely going to ease up on that very soon. This is just a morning show from South Africa called Espresso, and this host on the right was really asking this doctor on the left, the gentleman with the AirPods in his ears. The host was asking him, what does alcohol withdrawal look like? What are the psychological features that we're going to see? How can we prepare ourselves and manage alcohol withdrawal now that alcohol sales have been totally banned? The doctor did a pretty nice job explaining what the physiological effects of manifestations of alcohol withdrawal are and how dangerous it is. But unfortunately, he did not have many things he could recommend patients to do should they recognize these symptoms in themselves, and actually ended up in this segment recommending increasing exercise to treat alcohol withdrawal. We know that that is not safe treatment for any significant degree of alcohol withdrawal. And then a similar thing is happening in Thailand. 100,000, this article says 100,000 Thais are at risk from alcohol related withdrawals. Studies have shown that something like up to 5% of people experiencing withdrawal may develop an alcohol withdrawal seizure or DTs from that. So 5% of 100,000 is 5,000. People may experience complicated withdrawal due to a nationwide ban on alcohol sales in Thailand. And this is compared to something like 54 reported deaths in Thailand currently from coronavirus infection. This article, this opinion piece in the BMJ, talked about how fatalities or complications of alcohol withdrawal due to this policy may actually exceed COVID fatalities in Thailand. So very interesting to think about the unintended consequences of these policy changes. I wanted to review some changes that have been made in methadone treatment locally. SAMHSA has requested that the DEA allow exemptions to certain rules in response to the emergency for methadone, including allowing alternate delivery methods to quarantine patients so that they don't need to come into the methadone treatment sites, such as Evergreen, to pick up their medicines daily. Typically, methadone is only administered daily. You have to come in person to an opiate treatment program like Evergreen downtown and get your methadone dose and have directly observed therapy every day. The proposal requested doorstep delivery via medication lock boxes, and that these medications could be delivered by other support staff, and the DEA granted this request in March. It really is an amazing example of what people can do to promote local solutions and how those innovative solutions can be adopted more broadly. These changes to methadone rules were proposed by people here at University of Washington, including James Darton, who was my predecessor a couple years ago, was the ambulatory chief resident and works at Evergreen and Adult Medicine Clinic. Joe Merrill is also on this paper, and Judy Suey are some other names that might be familiar. And they published their experience in this report here, just about how quickly they came up with a plan to make methadone dosing safer in the context of a pandemic, and crafted this proposal, which was approved by the DEA. There are now blanket take-home dose exceptions that are available, thanks to the efforts of Jamie Darton and others. COVID-positive patients can now get take-home carries of methadone for up to 14 days. If they have any symptoms of respiratory infection, they can also get up to 2 weeks of methadone. If they are over the age of 60 and have medical comorbidities, they can also qualify for up to 2 weeks of take-homes. If they're stable and have earned a take-home already for their methadone, their visits can be reduced from 5 visits a week down to 2 visits a week. If they're unstable in regard to their methadone treatment, they can decrease from 5 visits a week to 3 visits a week. And for those who cannot safely manage any take-homes, daily visits are continue to be recommended. These slides here are courtesy of Dr. Joe Amero. And then other changes that were done to opiate treatment programs: methadone dose evaluations can be conducted over the phone or video. However, the initial visit must still be in person because a physical exam is required to start methadone treatment typically. And then in their paper, I thought this was really amazing. They looked at the before COVID era, February 24th through 29th, and the after COVID, March 30th through April 4th. The percentage of on-site visits during those periods were compared, and in-site visits decreased by 50%, which is really amazing. They decreased traffic through their clinic through Evergreen Treatment Services by about 50%. And something that was really remarkable was that actually the opioid treatment program at Evergreen maintained the same level of admissions, meaning they were able to get new patients started on methadone treatment at the same level, at the same rate as pre-COVID-19. So managed somehow in the context of decreasing, in a sense, decreasing patient access to the physical Evergreen treatment site, they were still able to maintain good recruitment and to keep methadone open as a viable treatment option for people with opiate use disorders. I'm going to quickly talk about changes to Suboxone. In-person visit requirements have been waived, and telemedicine can be used to start Suboxone and to monitor Suboxone therapy. The interval for checkups can be increased from weekly to twice monthly or monthly. You can defer urine drug testing for stable patients. This has been the trend in the field overall anyway, but now has been reinforced with official guidance. Patients who require isolation because of respiratory symptoms or COVID-19 can continue to receive treatment, of course. The overall thrust of our national opiate use disorder policy is to favor buprenorphine over methadone. It's just so much easier, and they reinforce that in their guidance. There's no initial dose limit. It's easier to titrate doses of Suboxone, you can dispense Suboxone from any pharmacy rather than requiring in-person visits to pick up methadone liquid from opiate treatment programs. Okay, we're going to move on to our last case now. We just have about 5 minutes left. This last case is called Quarantini. This is a 62-year-old patient of mine with severe alcohol use disorder. He's in recent remission since the January admission for pneumonia. He has benzodiazepine dependence, opiate use disorder that's very well treated on Suboxone, and he has a history of complicated withdrawal, including withdrawal seizure from alcohol. He had been on directly observed therapy with Antabuse for a first month with great success, and was attending 2 to 3 times weekly support meetings. He was meeting weekly with me or his psychiatrist or case manager, and these were spaced to every other week, given clinical stability and improvement and sustaining his remission. He achieved 3.5 months of sobriety, which was a personal record for him, but in mid-March, he decided he needed to visit his elderly mother and stepfather in Spokane, and called me to authorize early refills of all of his meds, and I did, and we made a plan to follow up by phone while he was in Spokane. Unfortunately, he was kind of lost to telephone follow-up and was gone for about a month. When he comes back to Seattle, I don't hear from him for a while, but he has an alcohol relapse. He gets very intoxicated, wanders into a neighbor's apartment, passes out on her couch. Police are called. The patient is arrested and taken to jail. There he withdraws from alcohol and benzodiazepines, develops urinary retention. He's brought into the ED. He's given a catheter to relieve his urinary retention, and he's treated for alcohol withdrawal with Librium, and then he's discharged home. So I call him for follow-up after hearing about all this, and he's clearly in pretty extreme emotional distress. I'm so ashamed, he says. I'm not going to say I'm going to kill myself, but I want it to end. He's drinking all day. He's using illicit benzodiazepines. Quote, I'm out of control. He requests inpatient treatment, but this has been difficult for him in the past due to insurance. And he says he was triggered to relapse by staying and actually caring for his stepfather and his mother. His stepfather repeatedly assaulted the patient as a child, and so he has very significant PTSD associated with his father, and found staying with him, caring for him, to be very triggering. So he tells me that he's had some withdrawals at home as well when he's tried to quit alcohol, and I wanted to, bring up the question is this patient safe to withdraw at home? The answer should be obvious to everyone. I hope the answer is no. He has a history of complicated withdrawal, including withdrawal seizures, and so he should not withdraw at home, and I advised him very strongly to never do that and to reach out to me or present to the emergency department. People who've had very mild symptoms of alcohol withdrawal when they've tried to quit before in the past, with no history of DTs or withdrawal seizures, might be good candidates for safe home withdrawal, supervised withdrawal at home. They have to be able to take care of themselves. They have to be able to take oral medications. And if that's the case and it's pretty mild, you may think about withdrawing them at home with Librium, with frequent phone follow-ups. You have to be so careful though, because of course Librium and alcohol can interact and be very, very sedating and dangerous. This patient is not safe to withdraw at home. I think I'm just going to put this slide up to remind us of some of the medication options that are available for treatment of alcohol use disorder and to help maintain abstinence. Now, this patient benefited from disulfiram, anti-abuse directly observed therapy. Naltrexone is not an option for him because he's on Suboxone. I think naltrexone probably would be a good option for him, especially the IM depot of naltrexone called Vivitrol. But unfortunately, he's on Suboxone, and so that would not be an appropriate choice for him. The data for acamprosate is not great, unfortunately. Topiramate can be an option in people who have comorbidities such as migraine or obesity. And gabapentin is something that's gaining traction as well, can help with concurrent pain disorders, and can also be effective in controlling mild withdrawal symptoms, as well as kind of maintenance therapy for better control of cravings. And then I'll wrap it up. There are many online alcohol use disorder support meetings that are available now. So the typical ones like Alcoholics Anonymous has moved on and done a very nice job organizing transitions of their meetings to online, and in many cases access to those is even easier than coming in person. And then another site that a patient told me about that looked really amazing is called Smart Recovery, and that often offers online meeting schedules and offers online modules to help patients work through issues related to substance use and recovery. So I'm out of time. That's the end of my talk. Thank you for everyone. If there's any outstanding questions, please just shoot me a text and I can bounce them to Kat and we can get them back to the group. But I want to make sure we have a little bit of a time for a bio break before Dr. Knight gets started. Chris, are you planning on getting started at about 10:15?
I can do whatever the group needs.
Okay, so why don't we, thanks everyone for your attention. Why don't we take a little bio break here, and plan to get started at 10:15.